the basic steps of all. We have divided this into 4 steps. One is limbal biopsy, second is pannus resection, third is amniotic membrane grafting, and last is explant management. So these and different videos will be shown, and you can stop anywhere you want. It will be more of interactive than a directive. If you have any questions, go ahead. If there is anything that you have understood, please feel free to ask about that. So we will start with the pre-op. We have a panelist, Dr. Alok Sati is already here. So he has a fantastic experience in, and those of you who are already doing, you can always share your experience. We'll have Dr. Himanshu also coming up for this. So first would be, Dr. Purvasha, you ready? So, for first talk, so what we'll do is we'll just take you through what exactly SLET is and what are the basic things that you look up before you take the patient into OR. So from pre-op to and in the last post-op, we are going to cover in this time. Over to you. Purvasha is a fantastic cornea surgeon at LGI Institute, Ambala. Over to you.
Good morning, one and all, and welcome to this primer course on simple limbal epithelial stem cell transplantation, or SLET. So let us first come to know which patients are exactly suitable and when is the right day to operate upon these patients. So as we all know, limbus is the most beautiful structure and the most fascinating structure of the ocular surface, and it harbors the stem cells in the palisades of Vogt, and any destruction of this limbus can lead to limbal stem cell deficiency, or LSCD, which may manifest in the form of indistinct limbal palisades, loss of normal corneal luster. The cornea just might not look very lusterful, and it might look very dull. There might be conjunctivalization along with pannus formation. There might be frequent epithelial breakdowns, which will be difficult to manage, ultimately leading to persistent epithelial defects. So what are the causes of LSCD? There's a very recent study which has come up, and this has found out data regarding the LSCD causes in South India. Now, the major cause that comes out is the ocular surface burns. These include the thermal as well as the chemical burns. Then comes the allergic conjunctivitis, and SJS, that stands for Stevens-Johnson syndrome, toxic epithelial necrolysis syndromes. The aniridia, ocular mucous membrane pemphigoid, and other cases like trauma, etc. So the major player here is the surface burns. Now, if we break down the causes into unilateral and bilateral, the major causes of unilateral LSCD here are shown in this pie chart, and as you can see, the major chunk of it is this ocular surface burns, which is forming almost 84% of the cases, and the rest of them are again taking up the minor chunks. So if we compare the data further, there is a male-female ratio of 2:1. Children under the age of 18 years are forming almost a third of the patients of LSCD, and the percentage of children is higher in cases of unilateral compared to cases of bilateral LSCD. Overall, a majority of patients were either children or young adults. So when we look at these surface burns, what comes to the fore is Lyme or tuna, or the alkali injury, which forms more than 2/3 of the causes of burns, and especially in children. And then comes thermal injury, and these are the other causes: cement, caustic soda, firecrackers, and other acidic injuries. So what happens? Why is it so common, this tuna thing? It's basically, as we all know, tuna is a white powder which comes in packets, and these tobacco chewers, they actually have this habit of mixing tuna with the tobacco, and these are very, very easily accessible and usually present in every household in rural India. And these also come in this fancy little tiny tubes with fluorescent looking tops. And these children, they get very fascinated, and they open it, and then with a blast this powder comes out, and usually this goes into the eyes, and they might present you with this kind of a presentation. And here this little one has presented to us 2 days after this injury just recently. And if you see, there is unilateral involvement. You can see there's total limbal ischemia, there is formation of symblepharon. Luckily for him, this was just a unilateral burn, and the other eye was absolutely normal. So when there is a unilateral injury or a unilateral burn, what are the management options that we have? There is CLAU. These are short forms for conjunctival limbal autografting, which was already done earlier, wherein 3 clock hours of superior and 3 clock hours of inferior limbus are transplanted from the normal eye to the injured eye. And then came the birth of CLET, or the cultivated limbal epithelial transplantation, wherein ex vivo cultivation of these limbal stem cells from the normal eye was done, and then it was a 2-stage procedure, and then the epithelial sheet that was regenerated was transplanted over to the affected eye. And finally came SLET, or the simple limbal epithelial transplantation. So CLAU, as we know, we required a larger area of conjunctiva and limbal donor from the normal eye, and so we felt we should not actually jeopardize the normal eye too much. Then as for CLET, we needed sophisticated lab support, and we needed regulatory bodies and time and manpower, and it was definitely a 2-stage procedure. And so we looked up to SLET, and which was the brainchild of Dr. Sangwan, and he published this in 2012. And this required a very small area of limbal biopsy from the normal eye, usually 1 to 2 clock hours. There were no sophisticated instruments or lab facilities which were needed. It was a 1-stage procedure, and the learning curve was not steep at all. So SLET that we used at LSCD was basically has been done for chemical and thermal burns, and it has found other uses also. For example, in microbial keratitis, there is data of it being used in post-surgery cases, post-radiotherapy, pterygium in cases of ocular surface squamous neoplasia as a concomitant procedure along with excisional biopsy with very good results, and in laryngo-onychocutaneous syndromes. So how do we measure success in SLET? We define success as a completely epithelialized, clinically stable and avascular corneal surface. A failure would be defined as progressive conjunctivalization of the cornea encroaching into the central 8 mm, basically recurrence of the LSCD. And additional criteria for failure would be a microbial keratitis affecting the SLET or a need for repeat SLET. The outcome, secondary outcome measure would be the BCVA, or the best corrected visual acuity. So what we realized was none of the donor or fellow eyes from which the normal limbus was taken demonstrated any donor site LSCD or any complications, and the epithelial defect had completely healed by 1 week. So if you have a look at the clinical case, this was the little boy who presented to us, and we managed him in the acute phase. And then finally there is a 360-degree, if you have a look at this is a 360-degree pannus which is present with symblepharon and obliteration of the fornices. But after SLET, we see that the stroma has cleared up, and there's a tiny area of a recurrent patch of pannus there. That's all, and the vision has definitely improved. So these were the pictures, clinical pictures of fluorescein stain, which was demonstrating how the epithelial surface had, the ocular surface had re-epithelialized after doing the SLET. So how does this work? There's a beautiful study published by our group. These are the placements of the limbal biopsy pieces in 2 concentric rows on the affected cornea over the amniotic membrane graft. Each of these pieces then acts as a nidus, and these the epithelial cells that are present, they then divide and then re-epithelize the surface all over the place. That is 360 degrees. So if you see, each one of them has started producing epithelium, and now the entire area is being covered by the epithelial cells. So finally the entire cornea is covered. So the study in children has also shown a very good result with complete surface epithelialization within 1.5 to 4 months. And the time interval is very important. We have to make sure that after the initial insult and the appropriate management, the eye should be quiet, it should be not inflamed, it should be epithelialized, and then only SLET should be attempted. So here the mean time interval between the initial injury and SLET was 6 months. The complete success was achieved in 1/4 of the cases, and partial success in 3/4 cases where the focal recurrence of LSCD was managed with a top-up SLET or a repeat SLET and conjunctival autograft. So if there is a presence of symblepharon and simultaneous keratoplasty, usually the SLET has a little lesser outcome. So now this was the picture on presentation. This was on the second week post-op, wherein the stroma has started clearing up and the epithelium has come back. A tiny area of LSCD is still present there, coming back, and this is the final after 6 months picture, wherein the stroma has also cleared up. Now here we had also, this is another case where we had also put in a conformer after SLET. And here again the stroma has cleared up and there's a symblepharon ring that we had put up, and then this is the post-op picture. There's another severe burn with 360-degree limbal and scleral ischemia with a lot of symblepharon, which has improved after SLET. Another series of pictures showing the intraoperative second week, third month, and the 1-year follow-up. So this could be a focal recurrence, which can again be managed by a top-up SLET. So the other indications that have been utilizing the benefits of SLET are the pterygium and the extensive ocular surface commerce neoplasia, wherein near total loss of limbus is usually seen after excision. However, with the simultaneous SLET that was done, we managed to get away without any LSCD. So which cases are not very great for getting a SLET done are these OCP cases, or ocular cicatricial pemphigoid with an ongoing inflammation. These are not good ones. There is the SJS patients, or the dry surface bilateral allergic conjunctivitis wherein the inflammation is still going on, or a very severe dry eye or where there is active infection that is going on. Also in cases of aniridia, because there is a bilateral limbal stem cell deficiency, so there is no area from where you can take a limbal biopsy. So basically issues with SLET are not that great. Pediatric eyes can also be managed very well. Inflamed eyes have to first be settled and the ocular surface has to be stabilized. The lids have to be taken care of, and only then the SLET has to be attempted. So basically SLET is a very, very beneficial procedure when done in the right patient on the right day, and this can actually give a very beautiful ray of hope in the lives of many little children who can then get back to life. Thank you so much.